Hi, I'm Judy Monroe, President and CEO of the CDC Foundation, and we'd like to welcome you to today's session and a conversation between myself and Daniel Dawes. We're going to be focusing on a current collaboration between the CDC Foundation and the Satcher Health Leadership Institute at Morehouse. It's very exciting for me to join with Daniel Dawes, who's the Executive Director of the Satcher Health Leadership Institute. So for myself, I've been at the CDC Foundation now 4.5 years. I came to the foundation having served 6 years at CDC as a deputy director. And I started my career in Appalachia, practicing medicine, and then ran a residency program in Indiana before being tapped by then Governor Mitch Daniels to become the state health officer in Indiana. And after serving for about 5 years in that role, I was asked to come to CDC and stand up the Office of State, Tribal, Local, and Territorial Support, which I did until 2016, and then came over to the foundation. For those of you that are not familiar with the CDC Foundation, we are an independent nonprofit. We're authorized by Congress to be able to work with CDC to help rally public-private partnerships to bring to bear up against and with CDC's work and with the health departments across the nation and health ministries around the world to help advance public health. So we work across the US with a number of projects. We're in about 130 countries, and at any given time we have about 300 active projects. And we have been extremely busy since January responding to the pandemic, which is one of the things that we do during emergencies, is to stand up our emergency response fund and go to work as an operating foundation. So Daniel, it's really good to be with you today, and even though we're in Zoom instead of in person. So you are a lawyer, an author, a scholar, educator, and leader in health equity and healthcare reform. And your research focuses on the drivers of health inequities among under-resourced, vulnerable, and marginalized communities. And you're a pioneer in looking at new approaches to how we examine inequities and look at the political determinants of health. You're forward-thinking, inclusive, and multidisciplinary in your approach to health policy, and you've authored 2 groundbreaking books, 150 Years of Obamacare and The Political Determinants of Health, published by the Johns Hopkins University Press. Both have received critical acclaim and rave reviews. And so I'm going to kick off our conversation today, Daniel, with the first question to you. Sure. I'm guessing that in some ways it must feel like your background and your work to date are really leading you to this point in history with COVID-19. This has exposed in such a real-time fashion our nation's health inequities. But before we dive into the COVID-19 specifically, can you just talk to us about our nation's health equity challenges?
Sure. Well, before I do that, let me actually say it's a real honor to join you as well, Judy, and especially for this important conversation around the opportunity gaps relative to health equity in America. So I want to publicly thank you for your remarkable leadership and your tireless advocacy, as you mentioned, right from tribal communities all the way up, looking at every single community in the United States. And I think with our partnership with the CDC Foundation and the Satcher Health Leadership Institute at Morehouse School of Medicine, I am very confident that we are going to be able to move this nation closer to becoming a more healthy, equitable, and inclusive society. So thank you so much for the honor of partnering with you. Let me quickly discuss then your question, right? Answer your question. Talking about the nation's health equity challenges. I think for too long, many racial and ethnic minorities, people with disabilities, and lower socioeconomic status individuals have found themselves in a very precarious situation. Their health, their lives have literally been hanging in the balance, right, for centuries. Many of them have been falling through the cracks of our healthcare system, our education system, our human services system, behavioral health system, you name it. And they struggle to live in a society that has erected barrier after barrier, which weaken their bodies and have hastened their deaths. So we know for over 400 years, these groups have experienced health inequities throughout the life course. And today, we now have over 7,000 peer-reviewed medical and public health journal articles widely documenting these disparities, right? The fact that you have African-American women having much higher rates of maternal mortality. We know that an infant a baby born to an African-American mother is 2 times likely to die than an infant born to a white mother. We know that children with asthma and all these other chronic diseases, right, developmental disabilities and so forth, strike disproportionately within communities of color. And if you are a person who has a serious mental illness, we know your life expectancy is significantly shorter, 56 years on average. So when you think about all of these, it's not thinking about them in a vacuum, but we have to look at the intersectionalities, right? Layering on them the drivers that have created and perpetuated and exacerbated in some cases these health inequities. And I thought that I would also share with you a quote by Michael Marmot. So Michael Marmot, right, a revered social determinants of health guru, has stated time and time again that the inequities or the life expectancy as a measure of health tells us a great deal about how we're doing as a society. But the health inequities in this society tell us even more, right? So you only have to look back over the last 40 years to see how we're doing today. In 1980, we ranked 14th in the world in terms of life expectancy. Then about 28 years later, right, not even 3 decades later, we dropped by 11 points to actually 25th in the world. And then after that, we saw a significant or alarming result happening with the decline in our life expectancy. So 5 years after 2008, we saw our rankings drop 10 places, right, to 35th in the world. Then 5 years later, in 2018, we actually dropped another 8 places to 43rd in the world. And why is this interesting? Because if you disaggregate these various racial and ethnic groups, right? If you were to, disaggregate all of the white folks in our country and, they created their own country, they would rank actually 50th in the world. If you were to look at all of the Black population groups in this country and put them together, they would rank 103rd in the world. And if we were to put all of the Native American tribes together, right, they would rank 143rd in the world. And things aren't looking much better as we look into the future. In fact, the Lancet actually published, I thought, a pretty groundbreaking study showing that in the next 20 years, we are expected to drop 21 points in our ranking to 64th in the world. Isn't that something? 64th. And then when you think about it now, in terms of where we are moving demographically, we know that in the next 20 years, we're really heading towards a racially pluralistic society, right? And we know that this year in 2020 marked the first time ever that children of color outranked under the age of 18 were actually, there were more of them than white children. So if these children are coming from communities, from families that are sicker and dying younger, this presents all sorts of challenges for us, right? So let's think about that. We know that on average, 83,000 African Americans die each year. It's costing us over $300 billion, and that's a pretty conservative number. And then there are all these national security implications for our country if we don't tackle these inequities. So I'll stop there to say that we certainly have come a long way. In fact, I think Dr. Satcher, who you and I both highly respect and has been a great friend, when he actually left his stint as Surgeon General and founded the Satcher Leadership Institute, he wrote a groundbreaking study that looked at from 1991 to 2000 and found that with all of the improvements that we had made in healthcare, with all the technological advancements, we had actually saved about 176,000 lives during that time period. But, and here's the clicker, right? But if we had taken an equity lens to that work, we could have saved almost 900,000 lives, African American lives, during that time. And so where are we today? We know that the disparities are alive and well. We certainly have a lot to do. They've been magnified during COVID, but I'm pretty hopeful that with our partnership, we're going to be able to move that needle of health equity forward.
Yeah, I'm hopeful as well, and it's fantastic to be able to work with you. So here we are. I mean, it is alarming when hear you speak about the history. So let's think about COVID. Talk to us about how COVID-19 has really just put such a bright light on these inequities.
Oh, absolutely. I mean, I firmly believe that we are experiencing a triple pandemic in the United States. Obviously, COVID-19 is one of those, but there are also the additional pandemics, the racial tensions, right? And the mental and behavioral health issues that have been magnified today. We know that loneliness is consuming our country. We knew that suicide and addiction were some of the leading causes of death in this country prior to COVID. And they've been magnified as a result of this pandemic. What we also know is that, you know, when you look at the underlying factors of cancer and asthma, heart disease, and other chronic diseases that are striking disproportionately within communities of color and lower socioeconomic status communities, it's quite interesting, right? As a result of these inequities, these higher rates of chronic diseases, these communities are experiencing a greater risk, or they're at greater risk of complications from COVID-19. And I think what's interesting about this is that, you know, many folks were surprised. And I can't tell you how many folks, and I'm sure you heard this, Dr. Monroe, from many journalists saying, were you surprised when you found out that, you know, racial and ethnic minorities were dying at higher rates? I said, oh my gosh, I wish it were a shock. I wish it were a surprise, but it's not. Because the inequities that predate COVID-19 didn't suddenly appear, nor are they inapplicable. So when you think about it, you know, minorities, people with disabilities, and other vulnerable communities still contend with neighborhoods that are largely devoid of necessary protective and health-sustaining resources, right? Mm-hmm. And they are still contending with the social and political determinants or drivers that created and exacerbated these health inequities over time.
Absolutely.
Yeah, absolutely. So Judy, let me ask you a question now, right? You mentioned, you know, that you've worked in healthcare, you've had an illustrious career in public health for your entire career, and I'm just curious as to, you know, how have you seen health inequities play out in practice in your time as a physician and as one of our most highly regarded public health leaders, and now even more so as the leader of a major nonprofit, right? A foundation that is leading these efforts globally.
Yeah, you know, when I started my career, I mean, my plan was really to be a practicing physician. I honestly, I don't know that I had thought much about health inequities until I got into medical school. And it didn't take very long before the health inequities that I was seeing really started to trouble me. And really was the driver of my interest in working with communities that were really in need and underserved. And so I took a National Service Corps commitment. I was a National Service Corps scholar, and that took me, originally I was going to plan to work on an Indian reservation, but I ended up taking a stint in Appalachia and working in the mountains and with rural communities. And yes. You know, those are these are communities that have longstanding systemic health
Sure.
and social inequities, and you know, there are higher rates of cigarette smoking and obesity, hypertension. I mean, so my first week in practice in Appalachia, I mean, I was just hit with all these inequities. They were walking in the door one after another with part of this was health illiteracy. They just didn't understand. And so I had an opportunity to really go to work in Appalachia, roll up my sleeves. And what I learned very quickly there was if we're going to tackle these issues, we've got to do them together. This is a multidisciplinary, you know, we need an all hands on deck approach. And so honestly, in a 4-year period, we were able to affect actually some systemic change because because wasn't shy about asking for help at all. And then I moved on into academia and became a residency program director. And one of the things that we had in the community was a very large Latinx population, and Spanish speaking only or limited English. And when I first got there, they didn't have interpreters. They were relying on the children. Well,
Wow.
that's not actually a great model.
Wow.
So there were a number of things we needed to do. And again, we rallied a multi-sector, if you will, at the hospital. We got all our friends together, went to the hospital leadership, and mobilized additional resources to be able to have skilled and professional interpreters. We started to address not just the health concerns, but we started looking at things like housing, and the hospital actually put some resources together to be able to help the community. We also did financial counseling. They've never had financial counselors to be able to really help the population, for their financial health as well. We put in a very equitable sliding scale model so we could have affordable healthcare. There were a number of things that we did. And again, I was able to see, wow, if everybody comes together, we can begin to affect change in local communities. The other thing, and you mentioned it before, with maternal mortality, the Black infant mortality was markedly higher. This was in Indianapolis. And so I had the privilege of working on a fetal and infant mortality review with Dr. Haywood Brown and Dr. Virginia Kane, two folks that I highly regard and as professionals and in public health. And so we would do this in-depth review. I mean, it was painstaking, in-depth review of every fetal death. And of course, what we uncovered were the social determinants of health. I mean, so many times it were all these other factors involved in that. So I really saw the health inequities play out in amazing and sad ways, but things that, again, we can do something about it if we come in force. And then coming to the foundation, to be honest, what's interesting, if you begin to look at the work the foundation does, almost all of our programs, one way or another, do address health inequities. Obviously, we do a lot of work internationally in multiple countries, as well as here in the US. And one of the issues we took on was maternal mortality. We had a project working with CDC and other partners. We've taken on a lot of work. When you look at our programs around chronic disease, obesity, hypertension, diabetes, I mean, you just keep naming them, and the disparities are there. The inequities are there. So keeps us busy, and we're committed to health equity.
Well, I learned something new today, that you've certainly been a trailblazer in this movement to address the social determinants of health, right? Seems like before this was in vogue, you've been working on these issues for a number, right, of years. And I know too, not only are you a trailblazer in that, but the CDC Foundation has been a leader, right, has been quite active during the COVID-19 response. In fact, I believe the foundation was one of the first nonprofit organizations that activated for this response. So would you tell us about some of the work that the foundation has been engaged in?
Now, thanks for that. So we were the first, at that time it was the novel coronavirus. We hadn't even named it COVID-19, but the novel coronavirus was emerging in January, and we leaned in and stood up our emergency response fund. So we were the first in the nation, and gained recognition very quickly for that, because we were on webinars and calling folks to action before others had really started to do that type of work. We did that, from my own experience. If we don't learn from our experience, we're bound to repeat the mistakes.
That's right.
And when you have an emergency, I mean, you've got to step in quickly, and we need philanthropy to step in quickly. We need private sector to step in quickly, and of course, government. So that's what we did. And by doing that, we've been able to do an amazing array of things across the country and around the world to help with COVID. All the way from, in the beginning, we started out by helping support those in quarantine. And you'll remember, it does seem like a long time ago, right? We had the planes coming in, and we had folks in quarantine in California, and the folks were coming in, they didn't expect to be in quarantine, right? So they didn't have
Right.
medications. I
Right.
remember we purchased a CPAP machine for someone with sleep apnea that they didn't have, or that had broken. So it was things like that in the beginning. And then we moved into an array of things. It didn't take long to begin to realize that there needed to be research, right? A lot of emerging research. We helped support a pregnancy registry in the US to be able to look at the impact of COVID on pregnant women and infants. We've been able to support data solutions in the beginning, especially for contact tracing. This was all new, especially at this scale. And so we've made what I've been really excited about is because of where we sit in the public health ecosystem, we can make some very strategic investments on the front end. And then what will happen, like with data solutions, we invested and then government came in behind and supported, for the sustainable. Because philanthropy is, has a job to do, but we're not there for long-term, expensive programs. That's where government and other entities come in. We've supported laboratory equipment early on, and then we've done a number of communication efforts, both nationally and locally. One is You Will See Me, which is directed at African Americans and to reach them and to message about wearing a mask. And we've got another project called How Right Now, and that one's addressing mental health. And then we've done everything from personal protective equipment early on, and even now we're concerned. I am concerned about the fall with the flu. And the one thing folks need to remember is the coronavirus is not typically a summer virus. So look how many cases we've had across the summer. We're entering fall and winter. That's cold and flu season, right? So we all need to be ready and prepared. And then we've done another body of work that we want to do more, and that really is addressing health equity. And we've been able to supply resources to local communities like Richmond, Virginia, where they had a Latinx community that honestly, they were on the verge of homelessness because they wanted to go to work. This was 6% of the population with 30% of the COVID cases in the community. And so we came in and worked with the mayor's office and the state and local community-based organizations. We bring in both technical assistance as well as funding when we can to help. We've got to mitigate, we've got to protect, and then we've got to get to the root causes for the sustainable change.
Well, you see why I'm so excited to partner with you. You take a 360 approach to this. I'm so happy to hear that.
Yeah, absolutely. Okay, so with that, let's pivot to our collaboration focused on health equity. And so, Daniel, from your perspective, talk for a moment about what brought us together, how we first met, and how we got this effort started together.
Oh, absolutely. Well, thank you for that question. And let me just say, I love your quote about, if you don't learn from your mistakes, you're bound to repeat them, right? And I think that is so true when we talk about health inequities during a pandemic. So one of the things that really brought us together is we've never been able to realize an equitable response during a pandemic in our country. And we know that it's the same group of people who are most negatively impacted during this time, and the ones who are always on the downside of advantage and opportunity when it comes to securing the resources that they need, not only to survive, but thrive, right? And who are these? Of course, racial and ethnic minorities, as I mentioned earlier, lower socioeconomic status individuals, people with disabilities, immigrant communities are usually the ones most impacted the worst. And I was saying to, Dr. Satcher that, my goodness, when you look back from 1793, right? The first major pandemic that struck us, or epidemic that struck us, coming all the way as a constitutional form of government, of course I'm saying. But when you look from that time all the way until today, we've never been able to realize an equitable response. And that was very concerning. We're in 2020. Certainly with all the technological capabilities, with all the expertise that we have, the knowledge that we've gained, we can stem the tide of this pandemic, right? So it doesn't have that impact. And I was sharing with David Satcher, and I said, I'm really concerned that we're not going to be able to do something in a meaningful manner, in a very timely manner. Because what I noticed when you look back at all of the studies as well, is that it's not until after a pandemic or an epidemic subsides, right? Post-event, that, once we're crunching the numbers, we're looking at the data, analyzing the data, that we come to realize, again, it's the same group of folks. So what's going to be different about this time? And Dr. Setcher said to me, do you know Dr. Judy Monroe? If not, you have to meet her. I have to introduce you. And I said, well, I know of Dr. Monroe, but I've never had the pleasure of meeting her. And I've only known about the great work that they're doing at the CDC Foundation. And he was saying, oh my gosh, she's done amazing things when she was at the CDC and beyond that, some of the things that you mentioned today. And I said, oh my gosh, do you think she might be interested in helping us to address these health inequities? And he says, do I? Of course. So he said, I'm going to reach out to Judy and see if we can get a meeting. And I understand that he contacted you, right? And I don't know that part of the discussion, but next thing I know, we were able to get a meeting on the book, and we talked about these issues, these concerns, right, that were happening. And I think at that time, we had a snapshot of what was going on. Around that time, about 100,000, a little over 100,000 people in our country had passed away owing to the COVID pandemic. And at that time, we knew there were certain data that we were able to finally get after struggling to get that data that showed that, there were striking racial and ethnic disparities, right? So the first was South Carolina, then Virginia with Richmond, allowed us to see who was being disproportionately impacted. And yes, our hypothesis was that African Americans certainly were probably going to be the most in those areas, but it was a lot more than we ever thought was going to happen. So we saw about 100% of people in Richmond, Virginia, right, who died from COVID were African Americans. We saw disproportionalities again in South Carolina. Then Milwaukee allowed us to see, in Wisconsin, allowed us to see a snapshot of what was going on there. And then all the folks initially who had died from COVID there that they had the data on were African Americans. And I thought, oh my gosh, this is even more serious than we thought. So we've got to work, with this sense of urgency and do what we can to establish something that would be, impactful during this time. And it was then that as we were brainstorming now in our session, and I want to thank you for helping us to think about what it is we can do, right? With the resources we have, with the expertise we have. And it was then that we thought, why don't we create, if data is such an issue, or one of the major issues, right, for us, and we're not able to get it, why don't we create a comprehensive health equity tracker that will allow us to track racial and ethnic health inequities and inequities among other vulnerable groups, right, relative to COVID. So who's getting testing, who's not? Are there issues with the labs, or are there regional differences in who's getting tested and how long it takes to get that test result? Who's able to get into a hospital, get to an ICU bed if they present with these issues? Who's able to get a ventilator if you're in there, or access to remdesivir? And how about this issue of vaccines, right? That is quite frightening when you think about the dearth of diversity of racial and ethnic minorities in, especially African Americans, enrolling in these vaccine trials for COVID. So it was a host of things that we thought about, and we said, we truly need something comprehensive. We need to be able to see the bigger picture, or get a better picture of what's going on, overlay that with these comorbidities that we talked about earlier, right? So asthma, and heart disease, obesity, tobacco usage, maternal mortality, et cetera, because it all comes together and it helps us to see things more clearly. So we thought, okay, by adding that, we can also add the behavioral health pieces to this, right? To address the triple pandemic that we talked about with loneliness. So we'll be looking at anxiety and depression and suicidality and addiction and Alzheimer's, and then overlaying that with the social determinants of health, but then also the political determinants of health. How do we, analyze the policies to see whether they've mitigated these health inequities, or have they exacerbated health inequities? And it's an exciting project to finally be able to paint that picture. So I hope that answers the question.
Yeah, no, that was a great answer. Great answer. And by the way, as you were talking, it was bringing back memories. The first day that you and I had our first phone conversation, I was in my home, and I had turned my home basically into a war room, because we're all working at home, and I had all these poster boards all over the house mapping out trying to think where we needed to be with how the foundation
Yes.
supported the pandemic, and having a balanced portfolio. I mean, because we do,
Yes.
I do like to think 360 and look
Yes.
across systems, and so that'll be my memory. Talking with the poster board. So can you bring us, with all this work, it's been great, bring us up to speed on where the program is right now.
Sure. So currently we have, expanded the partnership. So of course, CDC Foundation, along with Google, and then Google.org, which is their philanthropic arm, and then with Gilead Sciences, right, come together to help us figure this out. So there are different dimensions to this. We have met with a team of nationally respected health equity leaders representing various population groups. So from African Americans to Latinx individuals to Asian and Pacific Islander individuals to Native American communities around the country, both urban and rural, as well as bringing in folks who represent individuals who are struggling in rural America, right? And people with disabilities. And we've also brought in groups to represent the LGBTQ groups, right? Because we're interested in the intersectionalities. And so with these various leaders, we held a meeting several weeks ago, because the idea is we don't want to create a health equity tracker that has any biases towards one group, any algorithmic biases that discriminates against a group versus another. We want everyone to feel an ownership interest in the creation of this health equity tracker. It's not my tracker, it's not yours, it's everyone's, right? We want them to feel like they truly have built something that has, it really is about time, right? That has been, stuck behind for way too long. So we have said, listen, we want to get together, we want to harness that power of collaboration among all of you. And together, we had a week of incredible meetings to think about how we can design this, especially with the end users in mind, right? We have policymakers, we have researchers, scholars, students, public health leaders, medical leaders. How do we create something that each of these end users will be able to use to elevate health equity in communities across the country, right? And that's been the idea. So where we are today is we've had these meetings now, we've been doing our research, trying to figure out what this data platform should consist of, where we should be getting the data from. And we are excited because now we have created a health equity task force that will work with the engineers at Google, the data scientists at Google, to help us, conduct design reviews, to help inform the project at every single step of the way, and to help us see where there may be opportunity gaps that we are missing from our vantage point. So if there are things, we're based, as you said, in Georgia, obviously, I take a lens with the Georgia lens. I look at inequities in Atlanta and beyond. But we're interested to know what happens on the Navajo Nation, right? In the Navajo Nation relative to this issue and beyond. How about with the Apache tribes and others? So we'll bring in these groups, they'll continue to work with us. And with your team, I believe we're gonna create the country's most comprehensive data platform to track racial and ethnic health inequities in this country. So that's pretty exciting. And that's where we are today. And we expect to finish this by probably mid to late October. And then it's a work in progress. We can, we'll build it so we track the disparities relative to COVID, but beyond that, with these comorbidities that I mentioned, those will continue to be built out over the years.
Yeah, no, that's great. I know our team is really excited to work with you. And one thing I didn't mention when I talked about what the foundation's done during COVID is I didn't mention the nearly 1,000 people that we've hired as CDC Foundation field staff. We've got teams in every state across the nation with tribal organizations, territories, and 6 big cities. And along with that, we've got some senior advisors. And for the first time in the foundation, we've got like a chief science officer and a chief medical officer, and all kinds of support has been made possible because of this response. And so I know they're super excited diving into this work with y'all. Very, very good stuff. So I want to turn to your book, The Political Determinants of Health. And in that you describe, of course, social drivers that affect health. Is there an equalizer that can be used to facilitate health equity?
Well, so 40 years ago, the National Academy of Medicine developed a report titled Healthcare in the Context of Civil Rights, a report that was mandated by Congress because at that time they saw alarming racial disparities that were observed both in health status and healthcare. And one of the striking aspects of that report, centered on this quote. They said, although a full commitment to equality has never characterized American health policy, serious questions arise whether the present partial commitments to equality in healthcare will be maintained. And so for me, when we look at the root causes, as you were mentioning, the work that you all are doing to address the root causes of inequities, I think a lot of us have been so focused on the social determinants of health, and that is absolutely critical. It does play an outsized role in our overall health. But I believe that we're merely nibbling around the problem of health inequities if we don't look at those levers that have been pushed and pulled over time to concretize, to entrench these inequities in our structures, in our institutions, in our communities. And so to answer your question about the equalizer that can be used to facilitate this, I believe that policy is one of those equalizers. And I think that if we were to take an equity lens to policy in this country, we would see tremendously different results than we're seeing today. So Judy, I know time is of the essence. We're running down, and I just wanted to ask you one final question. If COVID-19 pandemic is a marathon, where do you think we are? Is it mile 6, mile 12, mile 20? And what else do you think is needed to tamp down the pandemic?
It's a great question. I'm going to say that we're at mile 8. And I believe that actually one way to think about it, because it is a marathon, I think each passing month is 1 mile in this journey. And I say that because we're still a few months away from having a safe and effective vaccine. And if you talk to the folks, this is really going to be a heavy lift to get this vaccine. The first, of course, when the vaccine comes out, it'll be in more limited quantity, and then we'll have more quantity. We've never really taken on in the United States anything quite of this magnitude, where we really want to, ultimately, everybody's at risk, and so you want to vaccinate everyone. So it's a bit of a daunting task. The vaccines also, some of them, one of the leading contenders may need to be stored at like minus 80 degrees. So the cold chain, just the distribution, there's a lot of complexity to this. And when you drive down to that local level, we need the local communities then to be ready to go when the vaccine's available. But we have a lot of distrust to overcome as well. So we have all of that. We also have the anti-vax, there's vaccine hesitancy. There are folks that, are fearful of vaccine. To overcome that is going to take quite a lot. And there's a lot on social media that really counters the public health message. And so I worry about that. I also worry about our frontline workers, both on public health and healthcare. They're tired. It is a marathon. And if you're only at mile 8, I mean, there's still a long ways to go. And so we need to support them. That's something I think is really critical to finish this pandemic strong and to save as many lives as possible. And then the long recovery. I mean, everything we've talked about in our session today, when you look at the inequities and how the job losses and the setbacks and the mental health, and it just goes on and on. We've got a long recovery, and that's why I would only give us at the 8-mile mark right now.
Well, I certainly appreciate that. I think your point about this being a marathon is absolutely correct. It's both a journey and a destination, right? A destination because we have to have some hope, right? That we're going to be able to see that finish line one day. But it seems to be a long ways off. Well, Judy, I want to thank you for being a part of today's discussion with me. And I want to thank the CDC Foundation for its partnership with the Sattrow Leadership Institute at Morehouse School of Medicine. we certainly want to thank all of you viewing this session for joining us today as well. And I hope that you've gained some new insights on the challenges of health equity, how we can work to address those challenges, how we can work to really harness that power of collaboration to realize health equity for all of our citizens, and the exciting collaboration that Judy's team and ours are involved in to help inform and advance that work. So again, thank you for joining us.